Welcome back to the Benefits Playbook. Today, I'm really excited to be joined by Dr. Spencer Dorn, who is the Vice Chair and Professor of Medicine at the University of North Carolina at Chapel Hill. Dr. Spencer, thank you so much for joining us today.
All right. Thanks for having me.
So, Spencer, we're going to spend a lot of this conversation talking about AI, but we're going to talk about it from a couple of different angles: how you see it impacting how doctors work on a day-to-day basis, but then how also it's changing how members interact with doctors. Before we get into that topic, though, I'd love for you to walk us through your career journey and where you got to where you are today.
Sure. So I am a native New Yorker. I trained in New York and then Boston. I came to Chapel Hill, where I am now, way back in 2005 to complete my training in gastroenterology, and started out with a clinical interest in kind of mind-body medicine, which I still am oriented around that clinically. I started out primarily as a researcher and then just got interested in why healthcare is so hard to deliver, and got more involved in helping to run clinics and procedure units and different types of programs. And it became very clear to me that technology was about to reshape how we practice medicine, how we run practices, and how people find us and all those things. So kind of got interested in clinical informatics. And I've been doing this kind of work now for a while, in different capacities. But I continue seeing patients, and I work for our health system, doing things related to digital technologies. I help with our School of Medicine and clinical programs, and I do a bit of writing, and just like to learn, like to share ideas.
You mentioned running a practice and practice management. For most folks, they go to the doctor, maybe they watch The Pit on TV, but they don't know what it's like to run a practice. What do you think most people maybe don't understand about taking notes, staying up to speed on the kind of the latest research? What does it take to actually kind of run a practice if you're a doctor these days?
Well, there's the running the practice, the orchestration of care, which most doctors, maybe they participate in somewhat, but usually there are people who do more of that than others. So, it's kind of like, to make an analogy, I don't know if it's a good one, like a restaurant, right? There's going to be a manager of the restaurant who's kind of looking at all aspects of what's happening at the front of the house, what's happening at the back of the house, how are customers being served, and then there are chefs, and then there are waiters and hosts, etc. So for running a practice, it's more about just figuring out what's the configuration of our team, like who are the people that we need involved. What does care look like for individual patients, members, people, whatever, however you want to refer to the people that we care for? What does it look like from start to finish? So that's kind of what running a practice looks more like. And, a lot of it hasn't changed in many ways, probably over decades. Being a good clinician means, caring for people, treating them with empathy and respect, and being a good listener and understanding, the science and the state of the art and keeping up with that. And just, doing your best each day for each person you serve. So a lot of that is constant. I think what's changed more recently is that people tend to have more complicated needs than before, in part because we're doing a good job helping people manage chronic diseases and helping people live longer. So we're seeing people with, in general, more either more complicated aspects of illness or multiple illnesses combined. So I think that's one challenge. And then that brings a related challenge with information, and how do you manage all the information about the person you're serving, about the information and the literature that may be related to the people that you're serving.
Well, so let's focus on, I loved your restaurant analogy. Let's focus on the back of the house. So the doctors, the PAs. You mentioned that those interactions in a lot of ways are becoming more complicated because you're spending time with patients that have more complex conditions. What do you think people don't necessarily understand of when the patient leaves? Walk me through what charting looks like, how staying up to speed on all that information looks like.
Yeah, so I'd say probably the clinicians are more the middle of the house. The front of the house is kind of, your front door, how people
Mm,
discover you. Maybe you could think of things like check-in and making an
mm,
appointment. And, the back of the house would be things like a lot of the administrative activities
mm,
or maybe scheduling, processing referrals, things like that. I think what you're getting at is the actual, care that happens that
mhm,
kind of all this is created to support. And that itself is a little more than maybe meets the eye.
mm,
I'm a specialist, so I take a different lens at this, but I think it applies to primary care and different specialties. But in general, there's a like, how do I prepare to see a person who's coming in? Figure out what their needs are, what's happened before, what maybe we're thinking like in our mind, maybe we want to do, like what are the types of problems we're likely going to address. Maybe pending some orders, getting some things in place, starting to write the note before someone comes in. And then there's the actual visit where someone comes into the office, you're seeing them online, and it's about, collecting more data, trying to go a little deeper on certain things, clarifying things, and then trying to come up with like, what's the right plan for this condition based on what the science says, but also what makes sense for the individual, what they prefer. And then there's the after the visit and someone leaves and there's often, a note to finish up, or there are results to process or coordination to happen or messages from patients afterwards. So that's kind of like I mean, it's a little oversimplified and it's not always as logical, but there's the before and there's work that has to happen before, which largely is about getting to know what you're about to see, who you're about to see, what the issues may be. And then there's the work in the middle, which is really about collecting information, interacting, making good decisions, hopefully, starting to write notes, writing orders, pulling up literature, etc. And then there's the after piece, which is usually more cleaning things up, following up on things, coordinating things.
And when you think about both the opportunity for AI, but some of the impact you're already seeing, is it spread across that before, during, and after care, or is it especially relevant in one of those phases?
I think it's spread across all, and I'd argue that it's even, it comes from when people are looking for care, and even before they're looking for care and necessarily know what they need. Almost all the people I see have seen other gastroenterologists. Sometimes they've seen many other gastroenterologists. So you can imagine they have a lot of records, and those records may be locked up in different information systems in both structured and unstructured formats. So a lot of the work I do is the night before I go to clinic, I review all these records and I start writing a note. Well, there's AI software that's starting to help summarize patient records for us. And it hasn't really hit a tipping point yet, but I believe it's going to soon. And then when we're actually working with someone in person or online, there's a conversation that's happening, and often there's a typing happening because, right, we want to capture what's
Mm,
being discussed and we want to write a note and we want to start writing orders, and maybe we want to look up some things in the record, or maybe we want to look at the literature, and there are AI tools addressing all of those aspects. Probably the widest used and the best known is ambient dictation or ambient documentation, which, it's your phone is listening to the conversation you and I would be having and generating a note as it happens. So I could look up and I'm freed from the keyboard so we can have a conversation without my being anxious or distracted that I have to
mm,
write a note. And some of these tools are going further to start, it hears that I'm saying, oh, well, we should prescribe this medication. It can start pending some of those orders. So AI is having a big impact there. AI is having a big impact on looking up the medical literature and figuring out what's the right medication to use in this situation, or people who present with these symptoms, what's the proper differential diagnosis. So there are a whole host of really effective AI tools there. And then when people leave the office, and then there's all this other work to do, like, processing messages or dealing with prior authorizations, and various other things. There are AI tools being applied there. So long story short, yes, AI is starting to touch various aspects
mm.
of care, both the care that people, the processes that happen before a clinician's involved, as well as what happens when a clinician's involved as well.
I think we've all had those doctor's appointments lately where you almost feel like, hey, I'm over here, because they're so focused on kind of typing notes. How is it changing your ability to be present during a conversation with with a patient? If you're not having to actively take notes, Do you feel more
Yeah.
engaged?
I think it depends on who you are. I like to, so I think I'm a very good typist. I have a lot of kind of well-designed templates and macros, and I do a
Mm,
lot of work the evening before to get to know who I'm
mm,
seeing the next day. So I feel like often I can just usually, I usually feel very comfortable typing without being distracted, and I don't feel like I need some help. And I sign all my notes within a few minutes of my clinic ending. However, other people feel differently. Other people don't like typing and they're not as good at typing. They may not be as efficient using the EHR. And I think for those people, those clinicians, it's very liberating to not feel that pressure of, I've got to jot this down. I have to write a note. And not only during the visit, but after the visit, because a lot of clinicians go home and they have a bunch of charts they need to sign off on. And there's this concept of something called pajama time, which is kind of, like after dinner when family's going to sleep, doctors staying up late at night writing, finishing up their notes and touching them up. So I think it can be very liberating. But I think the point is that it's not necessarily for everyone. If you look at the data, these AI scribes in general tend to be used by about 1 in 3, used heavily, routinely by about 1 in 3 outpatient clinicians. So that means 2 and 3 are like me. They're either using it more selectively, which I do, or they're not using it at all. So I think usually my answers to these things are, it depends. It's hard to
mm,
come up with like, it's always this way.
mm. Yeah, I don't think a lot of people understand that pajama time notion that you were saying of you get the kids to bed, but then you still have 2 hours of charting to do. What impact would reducing that pajama time have to just quality of life for doctors?
Yeah, I mean, it's easy to imagine, right?
Yeah.
Just like any, and first of all, clinicians, physicians are not unique. A lot of professions take their work
Mm,
home.
mm,
I wouldn't, wouldn't want to pretend like we're the only ones doing this. Um, but of course, it's liberating. Of course, it's freeing. Of course, it makes a difference, right? I mean, if you can gain an extra hour to your day to go to the gym, to get an extra hour of rest,
mm,
to read a book, to have dinner with your
mm,
family. I mean,
mm.
of course, these are meaningful benefits that I think will help sustain our profession, because the work's gotten very difficult for many people in many different ways. So I think we need these types of supports to help us sustain ourselves.
Let's flip to look at the other side of the doctor-patient relationship and more the patient now. One of the things you've written about is go back, a decade, maybe a little bit more, when patients started showing up with printed Google results. How did that change kind of the doctor-patient relationship when the internet started to give members more access to information?
Yeah, I remember because I was a resident at the time in the early 2000s, and I wrote about this. I remember that people would show up with printouts. This was pre-smartphones. You can just look at your phone. They would show up with printouts and, hey doc, I read this, or hey, you know, I was thinking about this. And a lot of my older teachers recoiled at that notion. It was like, whoa, what's going on here? And there was this like popular coffee mug that showed up that said something along the lines of like, your Googling doesn't equate with my medical degree or something
Hmm.
like that. So there was a lot of pushback initially, because this was really one of the first times that medical knowledge was starting to democratize beyond the profession. Our profession has long existed under what many have called a grand bargain, which was, doctors held all the knowledge, and the public trusted us to use it for their benefit, right? So we had the privilege of practicing and regulating ourselves because we were the gatekeepers of knowledge, and the general public just trusted. And this was kind of a bit of a fraying of that grand bargain in many ways, that the internet allowed people to look up and find information that was hard to access before. So yeah, I think most of us got used to that notion. Many of us welcome that, right? There's a lot of benefit to people being more informed. There's obviously a cost to that as well, because more information can mean more disinformation, or more empowerment can also sometimes mean more confusion. But I think many of us learn that this is just the new reality, and how do we embrace that? What's changing now is that search is being replaced by language models, right? So people are asking queries and they're getting back direct answers, right? Paragraphs of answers. And not only on text, there, as you know, there's an opportunity to speak as well. So it's kind of taking this pre-existing trend and it's supercharging it, and it's bringing it to a new level, and it's providing answers, yet the answers are very convincing. They may be out of context, but more than just answers, it's providing a type of clinical reasoning that helps people make sense of otherwise raw information from websites. So it's, people, it's not just answers. It's, you can ask questions. Well, what if I'm experiencing this? Or what would you do in this situation? So it's not just information from a generic source. It's information plus more engagement, customization, reasoning, et cetera. So it's a whole new world in many respects. And I think this trend is just starting. I think it's a dawn of a new era that kind of continues the last generation of changes.
One of the things we think about on this podcast a lot is employers who are managing benefits for their people. And so if you're an employer right now, I think you're trying to figure out, how is AI changing how my members or my employees interact with the healthcare system? So I want to talk about the future next, but kind of where we are today, what do you think are the positives of this first kind of big AI push? And then what are some of the downsides you're seeing in how members are interacting with their providers?
Yeah, I think, as we mentioned, I think democratizing information is a major positive overall. The flip side of that, of course, is that there may be information out of context, can be confusing, can even be harmful, right? And there's also potential for disinformation. So I think number one I would think about is, how are people accessing information before they've even decided to have care, right? To receive care, right? Most symptoms, most health concerns don't necessarily lead to someone actually seeking healthcare. So I think that's the first. And then if they are seeking healthcare, how are they using tools to help guide them to the right type of care? So we're starting to see a lot of kind of care navigation tools and I'm sure, I imagine that your company is developing some of this, but even within traditional health systems, or kind of standalone companies that are helping people make sense of, all right, these symptoms, this is maybe what you would consider doing next, and these are the types of places. And then lastly, there are new types of healthcare practices popping up that are AI first. So instead of the traditional doctor's office or the health system, there are actually AI first medical practices that are emerging, that just like there were virtual first medical practices that emerged during the pandemic, that some people may find very attractive and lean towards. So I think those are what I would be thinking about. How are people accessing information? How are people navigating care? And then finding the places and the venues and channels that they wish to receive care for. Again, generally positive, but the negative is it could be overwhelming, it could be confusing, it could be misinforming. People could go down the wrong rabbit hole.
As someone who thinks about this a lot, that AI first care, I think, is really interesting. What are you watching in that space to understand, is it going to be widely adopted, or are people going to be uncomfortable with that?
Yeah, I think things take time, right? Healthcare changes slowly. We are seeing a crop of startups that are orienting around AI first care. So these are completely new practices that are built with new ratios of clinicians to patients, because they're using AI to do a lot of the upfront work and then only passing to a clinician after a lot of that's been done. So like completely different types of models, different types of capacity, really capacity building. So I think that's one thing. But I go further. I think even beyond these kind of upstarts, we're seeing and will increasingly see people interact with AI before seeing a traditional clinician too, in a health system, in a medical practice. We'll start seeing, rather than the old school clinical intake, which was like a clipboard in the waiting room, that people were filling out, checking boxes or writing things that the doctor may or may not have actually would actually read. We're going to see people, when they come into a traditional practice, where they're actually interacting with AI first to kind of gather information, go through a discussion, and then clinicians coming in with access to that information.
That's a really interesting idea. Do you think that providers and health systems are going to try to own that first AI interaction as you go into the system versus being prepared for someone having talked to ChatGPT before they walked in the door?
Yeah, I mean, I think that's a great that's a big unknown, and there's a question. I think a lot about aggregation theory, which you or some of your listeners may know about. Is there just going to be a funnel, a top of the funnel, that there's going to be a race to control that top of the funnel, which will then kind of determine what happens downstream, and how does that affect existing health practices, health systems, et cetera? Or is healthcare a little different? And maybe there's only so much you can do at the top of the funnel. Because I believe people don't just want information, they want actual care. They want answers to their problems, not only in an information format, but actually treatment results. And there's a limit to how much you can do at that top of the funnel. So it's unclear. It's unclear where AI kind of reshifts and reshuffles how industries work, and where power accumulates, and how things shift. It's unclear to what extent that will happen in healthcare compared to other industries, but it certainly will happen on some level.
Another idea you hear a lot in the AI delivered care is when it's just tough to get care. So, for instance, I was talking to someone last week who said, I don't love the idea of taking a picture of a mole and asking ChatGPT if it's cancerous, but I'm more open to the idea if it's going to take me 6 months to get in to see a dermatologist. So, where do you see opportunities for AI to extend care when there's not enough provider availability?
Yeah, I mean, I like the phrase. I didn't coin it, but I adopted it. Healthcare has a math problem. There's just too much need and not enough supply, right? We don't turn out physicians. It takes a long time to become a physician. It takes a shorter time to become a PA or nurse practitioner, or certain types of therapists, but it still takes a considerable amount of time. And then there's a lot of time to train up once schooling is completed in those areas. So it's just like we have this mismatch of tremendous demand, not enough supply, inability to ramp up supply through human healthcare workers fast enough. So I think what you're alluding to is that sometimes AI is the best option, and because it can meet needs more immediately, and if a more significant issue is detected, maybe it can bounce it up and prioritize your hypothetical patient who needs to see a dermatologist being seen faster. So I think that's kind of unavoidable. And I'll also say sometimes AI alone is better, right? I mean, I think there's a challenge that, we often imagine, going back to it depends. We often imagine that this hypothetical patient, like ideally they'd see a world-class dermatologist who's just like, does the best skin exam and is so kind and compassionate, and their office is lovely and it smells like roses and all that. But no, like there are dermatologists. First of all, they can't get in to see a dermatologist. Second of all, if they can, not every dermatologist is world-class and great at what they do. So, I think in some cases, AI alone may be better than what's available. In other cases, AI is really the only good option. And the challenge there is how do we integrate it in ways that make sense to the rest of the system?
Do you think there's going to be a dynamic then where in areas of medicine where, to use your line, I'll say the math doesn't math, you're rural geography, you're in Medicaid and there's not enough primary care physicians. Out of necessity, do you think some of the AI innovation is going to happen there first? Or maybe it'll be a more interesting laboratory on what's possible?
Yeah, or maybe not in the U.S., right?
Mm.
Countries outside of the U.S. I think a lot about how certain countries in Africa, they skipped landline. Like a lot of regions of Africa, like they just didn't have telephones and traditional telephones in homes or workplaces, and they just skipped straight to
Mm.
mobile, right? Kind of a leapfrogging effect. So I think there are some parts of the world where just there's such an undersupply of healthcare that AI type tools may kind of leapfrog, building out, you know, a broad healthcare infrastructure. So I think that's likely, and I'm aware of some efforts to make that happen. And then yes, I think within the country, the question is, will certain underserved areas, is AI a patch that's more likely to be adopted there? I think in some ways, yes. Of course, there's the concerns of the opposite happening, that AI won't get to rural areas or won't get to underserved areas because of digital divide issues. And then there's also the worry that certain populations may be taken advantage of, or AI that wasn't designed to serve them will be applied to them and will somehow be either inaccurate or biased. But yeah, that goes back to it depends. All these discussions are nuanced, and I think it's important just to be open-minded and approach these things with a sense of wonder, of wanting to understand, because usually, like the brief sound bites that people gravitate towards, usually they're either overly simplified or just frankly wrong.
Well, let's build off of that, because one of the things you often hear with new technologies is that as a society, we overestimate the impact they're going to make in the near term, but then we underestimate the long-term impact they're going to have. How would you kind of critique your view on how AI is impacting medicine right now? Are some of the cynics now going to be proved wrong 10 years from now?
Well, I often quote that Amara's law, that famous law that it takes longer than it thinks, but we can't imagine like the eventual output. So I fully subscribe to that idea. I also fully subscribe to the idea that a guy named Melvin Kranzberg coined, a historian, that technology is neither good nor bad, nor is it neutral. So like it's not predestined what the technology does, but it will have an impact. So those are kind of two guiding principles that I follow, both Kranzberg's law and Amara's law. I think we're starting to see some early traction in certain pockets. I mean, especially we talked about ambient scribes, or we're talking about consumer grade AI tools to learn more about themselves and their conditions. So I think things in some respects are happening quickly, but on other respects, things are happening quite slowly. I mean, medicine today is not that different than it was 4 years ago before ChatGPT turned everyone on to AI. Things still happen slowly. We, by and large, visits still look the same way they did 10 years ago. There's a little sprinkling of some different aspects to it, but by and large, it's generally the same. And I think that's okay. While understandably, we need to move quickly, and people are in many ways desperate for newer solutions. There's still a lot at stake, and there's still a lot that we don't know.
I love what you said, that it's neither good nor bad nor neutral. When you think about kind of the evolution here, what are the ethical or kind of governance elements of this that you think are going to be most important?
Right. I mean, the notion of neither good nor bad nor neutral is that the technology has no destiny of its own, right? It has no, these are tools, right? These are tools. It's ultimately up to us as a society, as organizations, as individuals, to figure out how we utilize these tools to maximize benefit and minimize downsides. So organizations like mine have created governance around how we use these tools to make sure that they're being harnessed safely and effectively without, disadvantaging particular groups. Governance is super important, and it's something that all good organizations are doing now, and will continue doing. This is not just like a one-time project. This is like an ongoing, we're looking at a new tool. How do we evaluate its potential benefits, its potential drawbacks, so that we can make the best decision to serve those that we're responsible for caring for?
How do you think, if you turn that governance and ethical question more to the consumer side, how do you think, or are you worried about how members are patients are managing that as well? Do they understand that if they submit their medical records to an AI model, it's not the same as talking to your doctor about something in terms of governance and data protection?
I think it all goes down to it all goes back to trust. And if you look at national and international surveys, people, Americans, but also those outside the U.S., they're pretty distrustful of the government. They're also fairly distrustful of big tech companies. What people trust, at least right now at this point in time, is they trust their friends and people they know personally, and they trust their clinicians. So I think that's a big role that we must double down on, is that, like, forming the trusting relationship so we can help individuals make sense of information that they're getting from, consumer facing tools, which may be really great and may be really accurate. It also may be too much. It may be overwhelming. It may be wrong. But I think that's the role that our profession will increasingly play over time. And I imagine likewise in the benefit space, a lot, there are great opportunities, I think, to help members make better sense of the information that they're receiving, and help them make better decisions. But again, I think it's all about those trusting relationships.
What do you think is going to be the force pushing innovation forward? Is your hypothesis that some of the big tech companies are going to make the biggest gains? Is it going to be a bunch of kind of one-off smaller startups? Is it going to be a combination? What do you think?
Well, I think the force pushing it forward is the market, right? Healthcare is about 20% of the GDP. So most large companies want to be involved in healthcare just because it's hard to ignore. And market forces, whether it's through startups and venture funding, wanting to recoup investments, or publicly traded companies. I think it's unclear whether it will be big tech companies leading the charge or smaller startups. Both obviously have advantages and disadvantages. And then there are incumbent companies like electronic health record vendors that really sit in the middle of all this, and in some ways have the strongest position because all the workflows flow through their product, and they have the distribution. So it's unclear, and I think it would be hard to say, oh, it's going to be one specific aspect of the industry that will ultimately thrive. It'll probably depend on the problem space, on the potential solution, and we'll probably see a mixture of winners and losers in those areas.
What are the questions in this space that you think are most interesting right now? Let's look over the next decade. If you could go and talk to yourself in 10 years, what questions would you love to ask about what's going to happen over the next 10 years?
The question that really motivates me most right now is just, what does it mean to be a physician in this new world? And even more so, what does it mean to be a human being as things are changing so quickly? So, that's maybe too high level, but to me, it's just trying to figure out, how do our roles and responsibilities change? How do our relationships change? What do we gain? What do we lose with these new digital technologies? What are the things that we're not thinking about but need to be thinking about more? What are things we're holding on to too tightly that it's time to let go of? So those are the general questions that I'd love to ask my future self, or anyone, looking out into the future, is like, what do things look like, and how do we keep our eyes open and make the best decisions that we can, so that we don't go down the wrong paths, which inevitably we will, but hopefully we'll have the awareness to recognize we're going down the wrong path, so we don't keep going, and we'll have the agency and autonomy to shift gears. So those are some of the questions that really interest me now, and I think will continue to interest me moving forward.
Well, you're right. Those are big questions, but I think they're super interesting ones, and actually a pretty good note to end on. So, Dr. Dorn, if folks want to continue this conversation with you, how can they reach out to you?
They could find me on LinkedIn. They could find me on Forbes. They could find me. I'm not really on other social networks. I'm in Chapel Hill. They could find me. They could learn a lot about the great work that's happening at UNC Healthcare and UNC School of Medicine. So,
well, Dr. Dorn, thank you so much. I wish we could do this conversation in 10 years to see how some of these things have changed. But for now, thank you so much for joining me today and your thoughtful perspective.
Thanks so much, Kirk.